Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. Today, I'm joined by a special guest, Dr. Christopher Garofalo. Dr. Garofalo, welcome to the show.
Thank you very much, Rebecca. I appreciate you asking me to be on. We talk a lot about the poor standardized education that nurse practitioners receive relative to physicians. It tends not to be as standardized, it's not as rigorous, it's not as lengthy. And we think that creates a lot of problems in terms of being able to take care of patients, particularly independently, but also even while supervised. And there was a post recently that came out with a nurse practitioner student on Facebook on one of the nurse practitioner sites who was out earnestly asking, saying, "This is going to be my first time in a clinical setting and I'm looking for advice," is what she said. She's going to be at a primary care clinic. Are there any NP guides, booklets, etc., that should be purchased? And what should I review, study, or make sure I know before I begin? So there's two issues with this. The first issue is that someone who is about to go out in a clinical setting who seems to be rudderless, I think, for lack of a better word, about what they need to know and where to turn to get that. And then the part that really caught my attention was somebody who seems to be a nurse practitioner who's out in practice took the time to actually write a fairly lengthy answer, which was very nice of that person, except when you actually read through the description, almost every single paragraph and piece of advice that this person provided is simply wrong, medically wrong. And I really felt it was important to be able to point that out to your viewers and to others so that, this poor person who's looking for advice is going to go out practicing on day one already with a deficit of knowledge and getting bad information.
Yeah, I think that this post brings up so many important points. First of all, we don't know the identity of the person that's responding. I tried to chase it down to figure out who it was, if it was a real nurse practitioner or maybe some kind of a troll. They're using an alias that spells out something juvenile, so it's definitely not their real name. But I did find some other posts from this person in that group where they seem to be asking or discussing authentic issues, so they seem to be a nurse practitioner. But regardless, they're sharing some really detailed information that if they're coming from it sincerely, that this is how they really believe, that's a problem. And if they're just like spamming or trolling this group and telling their audience this stuff, that's really bad too. So either way, it's bad news. So take our audience through some of the really ridiculous things that we're seeing and that were brought up in the advice that this NP gave to other people on the post.
The first one is interesting, and I'll take it paragraph by paragraph. The first paragraph, the first piece of advice is to ask about insurance and whether the population is Medicare Advantage or commercial. Is it adults only or family? The point here is that the insurance seemed to be really important, quote, really important from this person. Now, most of us, Rebecca, live in the insurance world. Some of us who do DPC do not. But most of us who live in the insurance world recognize how important insurance is. However, if you equate this person, this student who's asking this question to a third-year medical student or an intern, the first thing you do not teach them is to say you need to focus on what their insurance is. There are so many other medical issues that should be discussed first, then you can consider the insurance. So that was really the first issue. And again, that could just be random. That was just the first thought off their head. But in the context of the rest of the response, that was very telling.
Yeah, I thought so. And I loved the very beginning of their response because they wrote, "Oh, it's a fun one for a Saturday morning. Takes me back to my early days in primary care. Most primary care is the same thing over and over." The cavalier attitude about primary care is just the same thing over and over again. That just sets the tone for what this post is going to continue to say, which is that primary care is so easy and all you have to do is this and know what their insurance is.
When I could tell you my experience just from my office this morning, that is not the same thing over and over again.
Not at all.
Just like everything else, 80% of your visits are probably the top 5 or 6 diagnoses, but that does not make it easy or that does not make it simple.
Yeah, you're exactly right. And they said that there are two really important things. One, what is the panel breakdown as far as insurance? And two, how does your supervising physician or your person providing your hours, how do they feel about prescribing antibiotics? And this person says, at least a third of your patients will be coming in for cough, fever, feeling bad. I think I have a UTI again. My ears hurt and are draining stuff. My glands are swollen, whatever. Most will not leave happy unless you give them an antibiotic. So, talk about your thoughts when you saw that.
Again, between the months of December and January and February, yeah, we see a lot of cough and cold stuff. Absolutely. However, the question about antibiotics, we go over this and we rehash this in primary care year after year. Yes, many people come in and they do have an infection. However, the studies show most ear infections, most sinus infections, most bronchitis are caused by viruses. They're not caused by bacteria. The overwhelming majority, 90-95%. And there are fairly strict and clear clinical criteria for when to suspect if it's a bacterial infection. For example, a sinus infection, symptoms less than either 10 or 14 days, depending on who you listen to, almost is always never a bacterial infection. So antibiotics should not be given unless they have particularly severe symptoms or they're a smoker. There are some things that allow you, again, clinical judgment. But antibiotics are to be used sparingly and with judgment. Now, the answer about patients not being happy. This isn't your Burger King, where we are here to make patients well and do that happily. But we don't necessarily need to make people happy. And if you're in a longitudinal relationship with many of your patients, you take time to navigate this. And when you've seen patients for 10, 15, 20 years, you navigate that. And that is part of what should have been, again, imparted to this student. Yes, many of your patients want antibiotics, but part of your job is to help convince them why they don't need it or when they do need it. And there's education and there's sitting down and there's longitudinal relationships. There have been some other studies, particularly over in the Netherlands, that says that for children with ear infections, if you actually give the parents a written prescription, or I guess now it would be electronic prescription sent to the pharmacy, but give them very clear guidelines. If your child's ear pain is no better in X number of days, if they get a fever, etc., then go pick up the prescription. Studies have shown that's what patients are looking for. They want to be heard. They want to know that you consider the seriousness of the situation, and they want to know what they can do if things don't get better. They don't want to be there at midnight going, do I have to go to the emergency department? They want the option. And most of those prescriptions never get used, never get picked up.
Yeah, I think the important lesson to someone that's just starting their clinical experience is how to learn how to differentiate viral infections and when is it appropriate to consider an antibiotic. But instead of giving that advice, this more seasoned NP says that what the student should really be focusing on is to learn what antibiotics to use for what symptoms and what conditions. So what he says is learn the basics of antibiotics for bronchitis, how to differentiate bronchitis from pneumonia in the office. Bronchitis, usually Augmentin or a Z-Pak, doesn't really matter. Ask them what they took last time and how long ago. Ask them what usually works for them. If they want, give them a steroid, either Medrol dose pack or I like prednisone, 10 milligrams for 5 days at 3 p.m., no taper. Give it at 3 p.m. because people generally get more congested at night, and this allows the steroid to peak right about bedtime. Unpack that for us, if you will. There's a lot.
Yeah, there's a lot there. I will give kudos to the person. Augmentin and azithromycin are very appropriate medicines for a bacterial bronchitis. That's about where they ended off being really correct. I don't want to nitpick too much. It does matter what you pick. Medicines have different side effects. Your azithromycin is going to be much better tolerated than your augmentin. Augmentin is more likely to cause a rash. It's more likely to cause diarrhea. It does matter. Now, when you're in the trenches, does it really matter? Yes, I would still say the answer is yes, it does. These are not trivial matters. These are not to be taken lightly. Can you use either one equally? Yes, you absolutely can. The guidelines say that. But again, that's where the difference goes away. The part that really got me about this was the whole quote about prednisone. First of all, just give it to the patient if they want it. Again, there are fairly clear guidelines on when bronchitis or other respiratory infections need something like prednisone. Prednisone, although we do use it very frequently, is not something you want if there's a bacterial infection because that can suppress your immune system. You give it when it's needed. And when it's needed is, again, what this student should be focused on. When do I give the bronchial patient? When do I give them prednisone? When do I not? Again, kudos. So prednisone 10 milligrams, 5 days at 3 p.m. Again, they're batting 300 here. 5 days isn't appropriate without tapering. Absolutely. 10 milligrams of prednisone, you could argue whether you give 40 or 50 or 60. 10's not going to do anything. So now you have taught this student that you can give them a medication of which they can get all the side effects and absolutely no benefits. Further, I can't tell you how many patients I see, and although this is not with bronchitis, I have a ton of patients who come back to see me in the summertime because they get treated for 7 days for their poison ivy at an urgent care. 7 days isn't long enough. They come in, I give them 2 more weeks and they're better. Those things matter because if you undertreat with prednisone, you expose to risks and you don't get the benefits, and the patient's going to come back and see their primary. Finally, 3 p.m. 3 p.m. is the absolute wrong time, and it's the wrong reason. Prednisone will much more likely make people feel awake. I tell people, do not take prednisone before you go to bed unless you have a lot of chores you need to get done through the night, because you will not sleep. Prednisone should be given in the morning. So there's just so much wrong with that.
Yeah, when I read this, it reads like he was working with somebody and that's what they did. And so that's now he's telling this person, now this is what you should do. And here's and speaking with such authority. But this is the problem with apprenticeship or learning from someone else in a non-standardized way, and also without actually considering the pathophysiology, the underlying reasons that we treat things and how they work. If you don't actually think that through and use critical thinking skills, then you're just mimicking what someone else has done or what someone else has told you, which as in this case, may be completely wrong.
The other thing about this is most of the time when medical students and residents go out and they do their clerkships and their internships and they do their different rotations, there usually is some semblance of a syllabus that they get. It may be written, it may be online. I know medical school is much different now than it was when I did it years ago, but there should be some direction that these students are getting that would help answer some of these or a lot of these questions. But again, it doesn't seem as if they're getting that. And again, that gets to the issue of the standardization in their education, which we've talked about before.
Yeah, you got to read. You got to read. You don't just go to Facebook and get some advice or see what other people are doing and mimic it. Yes, you see the nuance when you get into a clinical situation, but you should already be coming into the clinical situation with a fairly strong fund of knowledge, which is why, even though now medical students, and even in my day, we did start getting some clinical exposure in the very beginning, but we spent a lot of those first 2 years building up that foundation so that we would then be able to apply it and not have to go to Facebook to figure out what the heck we were going to experience in the clinical rotations.
And this is not to say that physicians and students, medical students, don't bounce ideas off of one another, don't talk about things. We do this all the time, but not with such the basic information like this. You have to have that basic information. Again, I could argue with my pulmonology friends whether 60 milligrams or 40 milligrams of prednisone is better, but they both work. That's not the level that we're talking about. We're talking about the most basic level here.
Right. So let's continue on with this advice because continuing in the lungs, he says that she needs to learn how to distinguish between bronchitis and pneumonia. And he says with pneumonia, patients usually look sick, hoarse cough, can't take a deep breath because of knife stabbing pain in the lung, lungs sound terrible, sometimes fever, but adults don't run fever very often. Ciprofloxacin, send for chest x-ray and have them take over-the-counter cold flu medicine for cough.
Again, kudos to this person. Pneumonia is a different animal. He got that part right. But again, there are scoring systems for pneumonia. There are pneumonia severity scoring systems that say if this person has pneumonia, can I treat them as an outpatient? Do they need inpatient? Those are the types of things that this student should be learning about. And using vague terms such as the lungs sound awful. Yeah, the lungs can sound wheezy and that sounds awful, but that's a whole other presentation than a pneumonia. And oftentimes pneumonias are subtle. Again, this is one of those things where when you're a medical student and the attending physician is listening to the lungs and they're like, listen and tell me where you think the pneumonia is. And you listen and you don't hear anything different. After 10 or 15 years of listening to lungs, you're like, I think this person has a left lower lung infiltrate. And you get their chest x-ray and sure enough, that's where it is because you heard something different. But that does not get picked up right away. That gets picked up after thousands and thousands of lung exams. The choice of Cipro here. This, I just, again, Cipro is the absolute wrong medication. This person is in the ballpark. Quinolone medicines, ciprofloxacin, gadafloxacin, levofloxacin are appropriate for pneumonias, but not Cipro. And I'll just cut to the chase on this. Cipro does not get into the lung tissue. There are what we call respiratory fluoroquinolones, which are gadafloxacin and levofloxacin. They are meant for lung stuff. If you've got a UTI, use Cipro because Cipro will get your UTI. It will not touch your lung stuff. And that's even if you want to use a fluoroquinolone. Fluoroquinolones have a black box warning against things like tendon ruptures. People have torn their Achilles tendon. I have seen it in a patient or two. I've seen patients who have lots of muscle aches, and some of that is even permanent. So quinolones are not the first line choice. This is where you're best to stick with either your Augmentin or your azithromycin. But if you do choose a quinolone, Cipro's not the one.
Yeah, and I'll just throw in that really there's not any significant benefit to using over-the-counter cough or cold flu medications. Sometimes you tell people to do it just to give them something to do, but there really isn't strong evidence for any of those over-the-counter medicines.
Yep, exactly.
The next thing they talk about is UTI, and they say the MA should do a UA, urinalysis, before you see the patient and dip it. If it looks somewhat positive, Macrobid, Bactrim normally are fine. Again, ask them what they usually take and when. Ask them if it's a common thing. And if female, ask them if they've been to a gynecologist in a while. I've never done women's health. Just send them to gynecology and let them give an opinion.
You know, I know there are people out there who don't do a lot of GYN stuff. It's particularly, I would say, probably more common amongst internal medicine than in a family practice setting. There are a lot of patients who don't want to have a guy do their GYN stuff, so they do go to GYN. However, UTI is just bread and butter to be able to manage in a primary care setting. Yes, do get a urine dip, and you probably want to get that culture because if these are repeated, you want cultures to know what's going on. But this does not necessarily need to go to our GYN colleagues, have a lot of other things to manage and a lot of other things that I need them to deal with, such as postmenopausal bleeding. Please leave the UTIs to me. If they do get frequent UTIs, they may need someone. They may need, but that's more likely to be a urologist.
Exactly. So now we move into ears, and he says can be a bit of a problem because some eardrops can be pricey. That's when knowing what insurance they have helps. If you look into their ears and crud, have MA wash their ears and look again.
That's good advice. It is hard to look in there. But again, ears, and so here we go. Let's look and think about what do we need for eardrops? First of all, eardrops would imply that you have an otitis externa or a swimmer's ear. Again, most of the time, unless it's the summer, and I guess in Florida it's summer most of the time, but up here in the Northeast, we have a very specific period of time in which we tend to see otitis externa. Again, the focus should be on what does your ear exam look like? How do you differentiate between an otitis media and an otitis externa? Those are really important. Otitis media has its own complications in terms of hearing. Otitis externa has its own complications. That can go to the mastoid bone, all sorts of different things that can happen with that. The treatments are different. Some are eardrops, some are not. But again, there are generic eardrops here that you can use. Insurance usually doesn't give a concern in terms of generic eardrops. So again, the focus should be on anatomy, taking a history, and doing a physical exam. Those are the three real key parts. Those should always come before considering what the treatment is.
Absolutely. And then he talks about skin lesions and he writes, forgot to put it above, but this is common also. If it looks stable, whether it is concerning to you or not, send to dermatology. Some of the most expensive litigation is missed skin cancers. If it's something festering, try lancing it or at least open it up. Give Keflex, Bactrim, doxycycline, clindamycin. I've seen a lot more Ceftonir lately from hospitals, ERs, and urgent cares.
There seemed to be a little bit of confusion here. It seemed to me that what they're saying is if it looks okay, send them to dermatology. I don't know if there was a word missing or not. But even if it doesn't necessarily look okay, that doesn't always need to go to your dermatologist. You know, a good primary care physician who does their job day in and day out for years, you should be able to take care of about 85% of what walks through the door. We can't send every little skin bump to the dermatologist. They would have no time to be able to see other things. That's one of the beauties of primary care is we can act to what are we worried about? What are we not worried about? There are, again, very specific criteria, A, B, C, D, E, that you should be thinking about. This person, the student should be learning what are the A, B, C, D, E's of melanoma? What do I need to think about when I'm looking at a mole? Think about the ugly duckling sign. Okay, if I look at their back, is there anything that stands out to me? Those are the things that they should be thinking about. And it's a couple of reasons. Number one, there can be a dearth of dermatologists in your community. It can take 6 months, 8 months to see someone. That's a long time for a patient to wait if you're worried about something. Also, again, the issue of copays. Patients don't need to go see another specialist if they don't really have to. That's the purpose of having a good primary care home.
Or in my community, sometimes, Chris, they get referred to dermatology and then they see a dermatology NP or PA, and sometimes that's a fairly new graduate. It really is a problem. Like you said, I think it is. If you refer everything, then now the dermatologists have to hire people and it just creates a vicious cycle.
And it also, again, it prevents dermatologists from seeing the patients that I really need them to see. And it increases the costs to the whole system. And we've had this debate and we have this conversation amongst physicians. Do NPPs increase the cost of care, or they're supposed to decrease the cost of care? They don't. The studies all show they increase the cost of care. The Hattiesburg study, in fact, in Hattiesburg, Mississippi, they allowed independent practice for nurse practitioners, and they basically took that and they reverted back to the original plan, which was to have them be monitored because it costs the system too much money by doing all these extra referrals. So we have good data on that, actually.
The other thing to mention on this skin, where he talks about opening up things and giving antibiotics, like you've said before, there are guidelines. There is evidence for when you should use what type of antibiotic based on what your level of suspicion for a bacterial infection of the skin. There's also data that when you lance or open an abscess, you don't need to give antibiotics at that point once you have drained it. But what he says is very telling, which is I've seen a lot of this type of antibiotic being used. So I've seen it being used, so let me do the same thing. It's mimicking. Maybe those hospitals are using more because they're seeing more antibiotic resistance. We do get data on that from our health departments, whether there are increasing levels of resistance in our community. So it's not just willy-nilly. I've seen a lot of people do this, so that's what I'm going to do. That's really the wrong way to go about practicing medicine. So the next thing that he talks about is that he was advising the student two things. One, find out what kind of insurance panel the practice has that you're going to be rotating in. And two, find out what your attending or your supervising person's opinion is on antibiotic use. And so he goes on to say, if whomever you're working with isn't keen on prescribing antibiotics for every complaint, print up some patient education sheets to give them, meaning the patients, and be prepared for pushback.
You're going to get pushback on lots of different stuff, not just antibiotic use. You're going to get pushback on vaccines. You're going to get pushback on starting statins. The goal here again should be, how do you address that? How do you manage patients who may not want to start certain therapies or take certain things? How are you going to manage it when patients have different expectations than you? That's a skill. Just like in life, you got to learn to do that in life, but you have to learn how to do it in the medical office as well. That is a skill that needs to be learned and can be learned. And there's a lot written out there about how you go about doing that. How do you address patients? Instead of standing up, sit down and talk to patients so you're more at an eye level or even a little bit below them. So it's not like you're standing there, over them, explaining things to them or dictating things to them. You want to be able to elicit patients' information. Why do you think you need an antibiotic? Those things, although they sound kind of basic, that happens. And that happens 20 years after you've been practicing, because it really adds information and can really help put patients' minds at ease and get them the right medical care. If we go back again to the ear otitis media examples, patients don't necessarily want an antibiotic. What they want is they want to be listened to, and they want to make sure that you have heard their concerns, and there are ways to do that.
Exactly. And then finally, this NP advises, as for resources, I use Wikipedia for general information about a diagnosis, ChatGPT to write patient education sheets, and drugs.com for drug dose. And he says, for example, I had a patient come in claiming her dad suffered Cotard's syndrome, and she wanted to be evaluated for this. I'm not even going to lie. I had no idea what that was. I never lie to patients when they come up with stuff like this. They're usually doing it for shock value anyway. So I Wikipedia'd the diagnosis. Know she has commercial insurance, so I told her she needed to go to neurology and gave her a referral.
Now, I'll be honest here. I didn't know what Cotard syndrome
No,
was.
me neither.
So I went and looked it up. I actually went and looked it up on Wikipedia because that was his favorite site. And it turns out that, yes, there's a lot of pictures of brains on there, but Cotard syndrome is not a neurologic issue. It's a psychiatric diagnosis. So the neurologist isn't even the person. So even when this guy, we assume it's a male based on the name, gives his own advice and follows his own advice, he seems not to be able to actually get the patient to the right place. Compounded mistake on compounded mistake. However, you actually read Wikipedia, which would not be my first choice, up to date or some other type of information source would be. You would be sending this patient to a psychiatrist. Or, again, you would be managing that in your own office. Patients come in all the time worried that their person has brain cancer. They're worried that their mother has heart failure, or they're worried that they have heart failure because these are the symptoms my mom had. Those things come in all the time. Now, the tricky part is a lot of times they don't come in telling you that. They come in with a headache and you're trying to reassure them that their headache is okay and it's not worrisome, and they're not buying it. And then when you ask the question, what's worried you about this? Oh my God, my second cousin had a brain tumor and I'm worried I have a brain tumor. Okay, because I asked the question and I got the information by taking a history and spending time, now I can reassure the patient better. Also, the offhanded remark that patients do this for shock value, I don't even know where that came from. I don't know what patient comes in and makes up diseases that family members have. I feel bad for many of these patients if this is the type of attitude that's taken by this person. You are a professional. Your job is to take their concerns seriously. That doesn't always mean that it's coming from a logical place. There are often irrational fears that our patients have, but our job is to treat them. And treating them means treating the irrational fears and sitting down and talking to them. Again, in this person sent someone to a neurologist who didn't need to see a neurologist and didn't get the treatment that they need and is probably still scared about it.
And Wikipedia is, it's not to say that physicians don't look up information. We do. But generally, Wikipedia is not going to be the place that we start or Google. There are actual legitimate medical resources. I use UpToDate pretty regularly. There are a number of different legitimate medical resources, textbooks, of course. And so that's where you're supposed to go for this information, not something that is just created online by anybody can put something on Wikipedia and then someone else can edit it, but it's
Right.
not necessarily the authoritative source for medical information.
Exactly. And that's not something that you should be giving your patients, that kind of information. I know this person also said that they don't like to lie to their patients. I will give some credit here. There can sometimes be a temptation to BS your way through a visit. I don't do that either. I have no problem telling my patients, when I try to do it in a joking way, look, I can't tell you what this is. I can usually tell you what it isn't. Okay. I don't think you have a brain tumor. I don't know why your head hurts, but I can tell you it's not a brain tumor, and this is why. So we have time to go and spend to look at what is causing it. You want to be able to reassure those patients, and you want to be able to make sure that you are not lying to them. You want to make sure that you're being truthful about it. And being truthful sometimes means being able to say, I don't know. And the studies will show you patients actually respect that a lot more than someone who tries to BS their way around things.
Absolutely. I think one of the things that's so sad is that you do have these students, and many of them, there are pages and pages dedicated to NPs seeking help from colleagues. What is it that's driving these students and practicing NPs to Facebook to get information?
So I think the issue gets down to their education is not standardized. Nurse practitioners used to have a background in nursing, their nursing education. Then they went out and they were nurses 5 years, 10 years, 15 years. Now, a nursing education and a nursing experience does not necessarily equate to medical experience, but these were people who were a little bit older. They had some background behind them, they had some maturity behind them, and they know how to be adult learners. And being an adult learner is very different than when you're back in grade school. You have to know where to find your information. And like you said before, doctors look stuff up, but we also know where to look, and that's really important. But what we know now is that most of these nurses, they go through nursing school, and some of them go right to a DNP program. They come out in 2 years or whatever with a doctor of nurse practitioner. They may be 25 years old taking care of patients independently. There are no physicians taking care of patients independently at 25 years old. And there are issues of sort of maturity, and I don't mean character maturity, educational maturity, and being able to be an adult learner. So the issue is these schools, especially the not brick and mortar schools, the online schools, several begin with, or at least one begins with the letter W, who just churn out nurse practitioner after nurse practitioner. They never set foot in a school. They never set foot in a brick and mortar. They don't see patients until they get to their clinicals. Their clinicals, however, are not arranged by these schools. These students have to go out and find their own preceptors. These preceptors have not been vetted. These preceptors may or may not have just finished school themselves. And when those preceptors aren't vetted and they have to find their own, again, they don't get syllabi. They don't get, here's what we expect you to learn in these 6 weeks of your clinical. There's no guides. It is just out there, and it's you figure it all out. There was the recent Bloomberg article that really delved into the poor state of nurse practitioner education. And I think that there was a response from the AANP, which, if you read it carefully, actually doesn't address one thing about their education. It talks about how nurse practitioners provide safe care. Yes, they might, but there is no statement that rebuffed or rebutted what the Bloomberg article pointed out, which is the education is substandard, not standardized, and it's just poor, and they're often left on their own. And I think until the nurse practitioner community figures that part out, I think there's going to be a continued problem. That's what leads people like this student to go online on Facebook and just, what do I do? I don't blame her for doing it. I understand why she's doing it. The system shouldn't be set up that, however, make her do that.
Very well said. Thank you again for joining me on this podcast. And if you'd like to learn more, I encourage you to get the books Patients at Risk and the follow-up book Imposter Doctors. And if you're a physician, please join our group, Physicians for Patient Protection. You can learn more at our website, physiciansforpatientprotection.org. Thanks so much, and we'll see you on the next podcast.